Good afternoon, everyone, and thank you so much for joining us for NAMI Maryland's 39th Annual Conference. My name is Sarah Weissman. I am a volunteer with NAMI Maryland. I will be your moderator for this session today. This workshop session is Maternal Mental Health in the Time of COVID, presented by Jennifer Payne from the University of Virginia. You can read more about our amazing presenter, including her full bio, in the digital conference program on the official conference website. This workshop will discuss how the pandemic has affected the rates of major depression and anxiety disorders in women, including in pregnant and postpartum women in the U.S. Both risk factors and protective factors will be identified. Treatment options and self-care strategies will also be discussed. If this is not the workshop you meant to attend, please click the back button on your browser or click on the conference drop-down on the left-hand side of the screen and select Sessions from the menu to return to the full list of workshops we have available. We will be addressing questions at the end of the presentation. If you have any questions as the presentation continues, please post them to the social wall on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our presenter after her presentation has concluded. If you have any comments, concerns, or technical issues, please post them to our social wall and our technical assistant will address them accordingly. Please be aware that there is a 20 to 30-second delay between the presentation and the stream on Conference Tracker. When this workshop session closes, you will be prompted to fill out a brief survey. If you would like to receive CEUs for the workshop, you must complete the survey in order to qualify. I'd now like to welcome our presenter for today's workshop, Jennifer Payne. Thank you so much for joining us today.
Great, and thank you for having me. And now I'm going to attempt to share my screen and get the slides going. And if my son were here, we would have no problems whatsoever with this. All right, so let's make this bigger and let's do slideshow, play from the start. And I think we did it.
You are all set.
All right, so as has been said, I'm Jennifer Payne. I have just moved to the University of Virginia, where I'm professor and vice chair of research. And I am happy to say that Charlottesville, Virginia is a lovely place to have moved to. And I'm happy to be there. So today we're going to be talking about maternal mental health, kind of a little bit in general, and then also talk about maternal mental health in the time of COVID. And let's see. These are my disclosures. I have research support from NIMH. I also own a patent entitled Epigenetic Biomarkers of Postpartum Depression. And in the past year, I've served on an advisory board for Sage Therapeutics. This is my talk overview. We're going to talk about first what we know about maternal mental health. We're going to touch on what's called adverse childhood experiences. And then I'm going to talk about the rates of depression and anxiety during COVID, presenting some novel data that I've collected. So this is new data that has not yet been published. We're in the process of publishing it. And then we're going to talk about the pandemic and maternal mental health in general and why the rates of depression and anxiety likely have gone up for moms. And at the end, I'm going to talk about why it's important to seek treatment and some self-care strategies. So what do we know about maternal mental health? Well, first, we know that women experience twice the rate of major depression during the reproductive years. And if you take a look at the graph on the left, what that shows is that the rate of major depression doubles at puberty for women compared to men and stays twice the rate of that in men until about menopause. So there's something about the reproductive years that increases the rate of major depression for women compared to men. And those of us in the field think that it is likely the exposure to the cyclical changes that women go through on a monthly basis, as well as the hormonal changes that women experience going through pregnancy, because it's those hormonal changes that begin at puberty and end at menopause that really mark those changes for women that increase the rate of major depression during those reproductive years. How common is perinatal depression? Well, we know that there's no evidence that the risk of major depression actually increases during pregnancy. And we know this from a number of large studies. I've listed one of them here. This was the 2002 National Epidemiological Survey on Alcohol and Related Conditions, in which over 14,000 women with a pregnancy in the past year were studied. And they found that there was no increased risk for major depression during pregnancy compared to women who were not pregnant. And I'm terribly sorry, I keep getting paged. But that the risk was actually increased during the immediate postpartum time period. So the risk was increased with an odds ratio of 1.52. So there's something really special about that postpartum time period that increases the risk for major depression. So about 10% of all pregnant women meet criteria for major depression, and about 10% of all non-pregnant women meet criteria for major depression. But in that immediate postpartum time period, the risk increases. We know that the rate is higher in women from lower socioeconomic status populations and in women with pre-existing mood disorders. So if you take women with pre-existing mood disorders, about 20 to 40% of them will be depressed during pregnancy, particularly if they have stopped their medications for pregnancy. The rate of relapse in women with mood disorders who stop their medications for pregnancy is actually quite high. So if women with major depression stop their antidepressants for pregnancy, about 70% of them will relapse with major depression in pregnancy. And the rate is even higher in women with bipolar disorder. So the studies show that 85 to 100% of women with bipolar disorder who stop their mood stabilizers for pregnancy will relapse with bipolar disorder during pregnancy. However, the rate of relapse in women with mood disorders who continue their medications for pregnancy isn't zero. It's about a third. So the studies show that in major depression, about 26% of women who continue antidepressants for pregnancy will relapse, and about 33% of women with bipolar disorder will relapse. And we think that's because of the metabolic changes and the weight changes that happen in pregnancy. So in pregnancy, the kidney function and liver function really increase. And in addition, blood volume essentially doubles during the course of pregnancy. And so it may be that blood levels, for example, decrease of medications during pregnancy, and that may open up women with mood disorders who are taking medications to relapse because their blood levels decrease during the course of pregnancy. So who's at risk for postpartum depression? Well, women with a pre-existing mood disorder are at a clear increased risk. So about 25 to 50% of women with a pre-existing mood disorder will develop postpartum depression. In the general population, about 10 to 15% of women will become depressed in the immediate postpartum time period. If you take women with a pre-existing mood disorder who are off their medications, about 70 to 90% of them will become depressed during the postpartum time period. We know that having a family history of postpartum depression increases the risk. So there's a genetic basis to postpartum depression. And there's also a lot of environmental risk factors that increase the risk. So again, having a low socioeconomic status, having a traumatic birth, environmental stress, such as economic stress or marital strife, also increases the risk. So why do we care? Why do we want to treat perinatal depression? Well, there's actually a myth that women should tolerate being depressed during pregnancy and during the postpartum time period for the sake of the baby. I think a lot of women are told to go off of their medications during pregnancy, and that they should just kind of suck it up and tolerate being depressed during pregnancy and postpartum so that their babies aren't exposed to antidepressant and other types of medications. Whereas the truth, if you look at the literature is actually pretty clear that depression during and after pregnancy leads to poor outcomes, not just for the mother, but for the baby. So first of all, there's the risk of maternal suicide. And maternal suicide is actually a major cause of maternal death in pregnancy, and it accounts for up to 20% of all postpartum deaths in the year after delivery. And psychiatric disorders are actually the leading cause of indirect maternal deaths in the year following delivery. Even though suicide is a fairly rare event during pregnancy, it's lower than the rate in the general population, it is still one of the leading causes of death during pregnancy and in the postpartum time period. And it is a preventable cause of death, and therefore it is something that we should be trying to prevent. In addition, there are a number of adverse pregnancy outcomes that are associated with depression during pregnancy. So if mom is depressed during pregnancy, she is more likely to have a preterm birth, a low birth weight infant, to experience gestational diabetes, to develop preeclampsia, and to have C-section. And we know that those pregnancy outcomes are associated with long-term health outcomes for the child that are not good. We know that there are cardiovascular outcomes that are negative for the exposed infant just by being preterm and low birth and undergoing C-section and being exposed to gestational diabetes. So if we could prevent these types of outcomes by preventing antenatal depression, we'd be improving the health not only of the mother, but of the child. In addition, there is a robust literature on the effects of postpartum depression and the effects on the infant. We know that postpartum depression is the most common complication of having a baby, and depression during pregnancy increases the risk of postpartum depression. It's probably one of the strongest risk factors for postpartum depression. And postpartum depression is associated with lower IQ, slower language development, an increased risk of ADHD and behavioral problems and psychiatric illness in the exposed child. And we think that's because when moms are depressed in the postpartum time period, they don't interact with or stimulate their child in the way they would normally. They don't talk to their infant in that high-pitched voice. They don't interact, they don't play. And so essentially they're depriving their child of the normal interaction that stimulates the growth of their brain. And therefore, there are all these adverse impacts on the child and their long-term consequences of being exposed to mom's postpartum depression. In addition, when mom is depressed postpartum, she has a lot of adverse behaviors that also affect the health of the child. So when moms are depressed in the postpartum time period, she's more likely to smoke and use substances. She's more likely to use the emergency room for healthcare. She's less likely to talk to her baby, less likely to give her children vitamins or use car seats, and she's less likely to get her kids vaccinated or go to healthy checkups. And therefore, it's important to prevent and treat postpartum depression. Now, I'd like to talk for a few minutes about adverse childhood experiences. This was based on a study conducted by the CDC and Kaiser Permanente from 1995 to 1997 in California. This was looking at what's called ACEs, or adverse childhood experiences. And basically what they found was that if people reported having one or more adverse childhood experiences, the more adverse childhood experiences they reported, the more unhealthy behaviors and unhealthy outcomes they had over the course of their lifetime. They found that 20% of people reported 3 or more ACEs, and that there was a graded dose-response relationship between the number of ACEs and negative health and well-being outcomes. And you can see here, these were the types of ACEs that they were asking for. So there were kind of 3 groups. There was abuse, neglect, and household dysfunction. And under the abuse category, they asked about physical, emotional, and sexual abuse. Under neglect, there was physical and emotional neglect. And then household dysfunction, they asked about mental illness, incarcerated relatives, substance abuse, mother being treated violently, and divorce. And then ACEs were found to increase the risk of negative health behaviors and outcomes. And the behaviors that they looked at were lack of physical activity, smoking, alcoholism, drug use, and missed work. And then they also looked at physical and mental health outcomes. So looking at obesity, diabetes, depression, suicide attempts, sexually transmitted diseases, heart disease, cancer, stroke, COPD, and broken bones. And what they found is that the more ACEs a person had, the more likely, I'm going to go backwards for just a minute, the more likely they were to have more physical and mental health negative outcomes and negative behaviors. And what this led to was the more ACEs you had, the more unhealthy behaviors and outcomes you had, and the more likely you were to lead to early death. And basically, the thought was that the adverse childhood experiences led to disrupted neurodevelopment, leading to social, emotional, and cognitive impairment, and the adoption of health risk behavior almost as a coping skill, leading to disease, disability, and social problems, and ultimately to early death. And when you think about this, this really gets perpetuated through different generations. So that if one generation is adopting unhealthy behaviors as a coping skill, that gets passed on to the next generation, because those unhealthy coping skills really are ACEs for the next generation, and exposures for the next generation. And then that next generation is already exposed and also has seen these unhealthy behaviors as coping skills, so they adopt them as well. And so there's this intergenerational transmission of ACEs and unhealthy behaviors, and ultimately it's this transmission of trauma, and whole communities are affected by this. And ultimately, this leads to the development of adverse community environments with multiple adverse community behaviors that leads to this environment that's just unhealthy for everybody. And so one idea I'd like you to take from this talk is that if we really can target having good maternal health, we can prevent ACEs, building resilience, and leading to improved mental and physical health outcomes, not just for mom, but for the next generation and ultimately multiple generations. With the big idea being that targeting maternal mental health will improve children's mental and physical well-being, decrease ACEs, and improve mental and physical health outcomes, ultimately, not just for that maternal child pair, but for the family and ultimately the community. And so that we can improve not only mental health outcomes, but physical health outcomes for multiple people and ultimately communities. So I'm going to turn now to talking about the effects of COVID-19. But if there's one idea I'd like you to take from this talk, it's that we can really improve outcomes for larger numbers of people if we target improving maternal mental health. So let's talk about the effects of COVID-19. What are the stressors associated with the pandemic, and do they affect women differently from men? So let's start with social isolation. I think there's less social isolation now, but certainly at the beginning of the pandemic, we were all socially isolated. And what you can see here in the top left corner is this is the proportion of participants by self-reported change in mental health since the physical distancing began and gender. And on the left-hand side, this was reported by men, and the middle is by female. And on the far right, this was reported by a gender diverse population. And blue is somewhat or much better. Red is about the same, and green is much worse. And what you can see is that women were reporting that their mental health was effectively much worse by this social isolation. And actually the gender diverse population was much, much worse in general. In addition, women in general were much more likely during the pandemic to be juggling childcare and work and dealing with teaching and homeschooling. I take care of primarily women in my clinical care, and I can't tell you how many women were overly stressed with trying to work from home and dealing with either childcare and or teaching and homeschooling all at the same time. And on top of that, many women are the primary caregivers for older adults, either their parents, their parent-in-laws, or even just simply older neighbors. What you can see here is that women and mothers were disproportionately affected by job loss during the pandemic. In the graph on the left, this was the percentage of adults ages 25 to 44 with children by sex and survey week who were not working due to COVID-19 related childcare issues. Women are on the top in the blue, men are in red at the bottom, and you can see that that men varied from about 8 to at the most 16% during the first 12 weeks of the pandemic, whereas women were varying from a low of 27 to a high of about 37% who were not working due to childcare issues. In addition, women were disproportionately affected by job loss during the pandemic. And there are several graphs here. The one on the right, this was women's unemployment rates, November 2019 through April 2020. This shows a breakdown by ethnicity. And you can see that women of color were disproportionately affected, but that women overall, you can see the rise in unemployment beginning in March of 2020, with an unemployment rate of about 28% overall for women. And the chart on the top left, this is women's share of jobs versus share of job losses. And the bluish green parts of the chart are women's share of jobs, and the purple is women's share of job losses. So you can see that even though women had a greater share of the jobs, they had a greater share of the job losses. In addition, domestic violence has clearly increased during the pandemic. These are just a few of the statistics from the larger cities in the United States. In New York, there was a reported 30% increase in domestic violence during the pandemic. Boston reported 27%, and Seattle a 16% increase. It's just phenomenal, the increase that we saw in this. In addition, women are the majority of the healthcare workers. Women make up 75% of the healthcare workers in the United States. And so they were less likely to lose their jobs as healthcare workers. But I can tell you that as a healthcare worker, healthcare workers were very stressed during this pandemic, even if they were not directly affected by the care of COVID patients. There were numerous stresses from personal protective equipment to being told that we might be redeployed. The mental health crisis in this country has been real and significant, and just trying to support our coworkers. There is a nursing crisis in this country at this time. It has been a wild ride during the pandemic. So let's turn now to COVID-19 and women's mental health specifically. Just in general, has COVID-19 affected the rates of depression in adults? And the answer is yes. This is one survey that was taken both before COVID-19 and then during the COVID-19 pandemic. This is a standardized survey. It's I'm not sure if they pronounce it a certain way, but it's the NHANES survey taken 2017 to 2018 in the dark green there. And you can see that it measures depression. And in the 2017 to 2018 era, the majority of adults surveyed really reported very little depression, with the majority of adults saying no depression and very few saying severe. And then you can see how the columns really shifted during the COVID-19 survey that was taken in 2020, where the rate of none dropped to about 50%, and a majority were saying moderates and moderately severe, and even the severe column became significant. There were a number of risk factors associated with more reports of depression, including having lower income and low savings and a higher number of various stressors. So what about maternal mental health? So this is one survey that was taken during the course of the pandemic. Before the COVID-19 pandemic, self-reported mental health among pregnant women and new mothers, about 15% reported depression, 29% reported anxiety. During the COVID-19 pandemic, about 40% reported depression and 72% reported anxiety. This is just on the basis of a couple of questions. So not necessarily the clinical diagnosis of major depression or anxiety, but very significant jumps in numbers. In addition, there have been several reports that have found that COVID-19 infection might be linked to a phenomenon called postpartum psychosis, which is a very rare condition, but apparently has increased with COVID-19 infections. There are at least 2 case series that I have found in the literature that have found increases in numbers of postpartum psychosis with active COVID-19 infection. We are seeing increases in psychotic symptoms with COVID-19 infection. And so this is not necessarily all that surprising, but it is interesting that there's an increase in postpartum psychosis with COVID-19 and active COVID-19 infection. Finally, does the pandemic increase the risk of postpartum depression? Well, the pandemic is stressful. Many people are stressed enough that psychotherapy is thought to be helpful for almost everybody coping with the pandemic. And many people with pre-existing psychiatric disorders have and are decompensating with the added stress. I can say that in my own practice, almost everybody has at some point during the pandemic at least been extremely stressed, if not decompensated, with the pandemic. There are a number of people, for example, like frontline healthcare workers, who are being exposed to enough trauma that they are developing new onset psychiatric disorders. But there are some situations that might be protective. I can tell you that some of my more introverted patients are very happy staying at home and not having to interact with other people, for example. I tried to answer some of this question. I have a partnership with a mobile phone application called Flow. This is an application that tracks women's menstrual cycles, but it also tracks women's pregnancies when they get pregnant. And it's basically a tool that charts mood, attitude, symptoms, and concurrently tracks menstrual cycles, fertility windows, pregnancy, motherhood, and menopause. And there are approximately 36 million women who are monthly active users across 244 countries. So this is a really particularly strong tool that gives you access to a large amount of data. It's available for download on both Google Play and the Apple App Store. And in my collaboration with Flow, we were able to partner together, and they were able to give me de-identified data sent in aggregate so that we could not obviously identify any one individual. And we did send this study through the Hopkins IRB, and it was acknowledged as a low-risk study. And every woman who had tracked their pregnancy and set the app to saying that they had delivered was sent within 90 days of delivery a mood survey, which was, how would you characterize your emotional state after giving birth? And these were the 6 options that they were given. The first was, I'm in high spirits. The second was, I can characterize my condition as emotionally stable. 3, I'm experiencing mood swings. 4, I'm experiencing anxiety, irritability, dissatisfaction. 5, I feel sad, hopeless, helpless, useless. I am scared for my child. I have feelings of guilt and shame. And 6, I have no emotions at all. I feel disconnected, emotionally exhausted, with no energy to take proper care of my child. And for this study, we defined postpartum depressive symptoms as answering either 4, 5, or 6 on the survey. And we were able to get de-identified data from the Flow app collected in aggregate and stratified by state in the United States. So we only took data collected in the United States, and we got data from 2 different time points. And the first was pre-pandemic, from January 2018 through February of 2020. And for that data, we had data from 159,000 women. And then for the pandemic time period, we had data from March of 2020 to March of 2021. And for that period, we had data from over 118,000 women. And our analyses assessed changes in self-reported postpartum depressive symptoms from a pre-pandemic period to the pandemic period. And what we found was that there was an increase in postpartum depressive, self-reported postpartum depressive symptoms. So during the pre-pandemic period, 6.5% of respondents endorsed postpartum depressive symptoms. And during the pandemic period, 6.9% endorsed postpartum depressive symptoms. And so that represented a 6.31% increase in postpartum depressive symptoms. So not a huge increase, but a definite increase. And you can see here that the rates of postpartum depressive symptoms increased over the course of the first year, so that the rates really kind of kept increasing during the course of the pandemic. And we looked at this by state and found that 36 states showed an increase in postpartum depressive symptoms during the time periods. 7 showed a decrease, actually, and 8 showed no change. We then did some statistical modeling. We used linear regression models to investigate the association between individual state-level factors and change in state-level postpartum depression symptoms. And all variables were standardized prior to regression modeling to account for differences in scale. And individuals that were significant at the level of 0.05 were retained and entered into a multivariate regression model. And this was actually, we had some very interesting results with this. So these were the factors that we investigated. So first we looked at total COVID-19 cases per 100,000 residents, total COVID-19 deaths per 100,000 residents, the percent of population staying at home per state, percent of change in jobs from February 2020 to April 2021 per state, and women's unemployment rate per state. And basically what we found was that there was a negative association between the total COVID-19 deaths and postpartum depression symptoms and women's unemployment rate and postpartum depression symptoms. And just to make sure that you get this, states with a larger unemployment rate in women showed a smaller increase in postpartum depression symptoms compared to states with a lower unemployment rate in women. Meaning that states that had more unemployment in women had a lower rate of postpartum depression symptoms. And states with a larger death toll had a smaller rate of postpartum depression symptoms. This was not at all what we expected. And so why don't we speculate for a minute why this might be? So women tend to do a lot. So we juggle a lot. And it might be that some groups might have benefited from staying home / social distancing during the pandemic. And some pregnant and postpartum women may be in that category. And so being unemployed and being pregnant and postpartum may have been an advantage for some women. And this has been shown in several other studies. There's a study in Italy that showed that women who were home pregnant women who were home during the pandemic had lower rates of postpartum depression symptoms. And so it may be that pregnant women who were unemployed during the pandemic had lower rates of postpartum depression symptoms because they weren't juggling as much as pregnant women who were working during the pandemic. And similarly, states with larger death tolls, it may have been more likely that women who were pregnant in those states were more likely to be home in states where the pandemic was raging more seriously. So it is likely when we get through the pandemic and are able to look at different populations, it may be that some populations have greater increases in postpartum depression symptoms and other populations were protected with postpartum depression symptoms. So other groups are likely to have increased rates of mental health issues directly related to the stress associated with the pandemic. So for example, working parents with young children, racial and ethnic minorities, frontline health workers, and teenagers, I think are populations that are more likely to have increased rates of mental health issues. Overall, there's likely an increased risk of mental illness during the stress of the pandemic, but we may find pockets of people who were protected under certain circumstances. And pregnant women under certain circumstances may have been one of those populations. Regardless of all this, we clearly need more mental health providers. And what this shows is that we have a dearth of mental health providers. If you look at the bottom chart, this shows that there is a negative change in psychiatrists compared to neurologists and primary care providers and all physicians from 2003 to 2013 in terms of the numbers needed to treat people, and we are in desperate need of more mental health providers, even more so today. So let's turn now for just a moment to talking about treatment and self-care. Self-care, I think, has become a very clear requirement during the pandemic. And it's important that everybody make a stress management plan. I emphasized this at the beginning of the pandemic, and I've been emphasizing it again as it became clear that we were in yet another wave, and that it wasn't going to be as easy as we thought it was going to be, and that we were going to have to go back to masking and getting booster shots and things like that. It is important that everybody sit down and think about, okay, how am I going to manage my stress? And quite frankly, we should be doing this outside of the pandemic anyhow. But everybody should take a moment and think, how am I managing my stress? And if I'm not managing it, how should I be managing it? And let me put a plan in place. Exercise is probably the number one thing that you can do. And by exercise, I don't mean go and work out for 2 hours a day. I mean, take a walk, do yoga. I think working with weights, occasionally is a wonderful thing, but I don't mean kill yourself. But regular exercise, moving your body, in a way that you find enjoyable and doesn't leave you dead is a really important way of managing anxiety and stress. It's also important to have fun, building in activities that you enjoy, particularly if you can do it with others, is a great thing. I love this picture of the little boy with the paint on his hands. I think we forget as adults that there are things that we can do that are creative, that we don't have to spend a lot of money on, that can be really fun. And so building those activities into our life regularly can be something that is a real way to experience joy and relaxation. I also think regularly practicing gratitude and positive thinking is something that is a way that decreases stress. Being grateful for people we have in our lives, for things that are going well, for things that you see that are beautiful, and experiences that you have that are positive, is a really great way of relaxing your body and feeling good. In addition, every time you catch yourself thinking something negative, trying to switch it around and think something positive is a great practice to put into play. Every time I find myself grousing about something, I try to think, well, this is the universe's way of giving me an opportunity to practice some skill, which sounds a little bit wacky, but really does work. It makes me laugh, and when I go at something that's difficult from that perspective, I usually do much better at it than when I go at it from a negative perspective. Finally, I think it's really important that if you're struggling, just get some treatment. You need to see a psychiatrist, go see a psychiatrist. If it's hard to see a psychiatrist, go see your primary care doctor or your OB-GYN, and see, and maybe start with a therapist. It is hard to get in with people these days because there is a mental health crisis. And so if you think there's a possibility you need to see someone, start today, make an appointment. It will take a while to get in. You can start with your primary medical doctor. There are a lot of online options now, so you don't have to stay within your zip code. You can see someone across town or the next county over. There are tons of books on cognitive behavioral therapy, dialectical behavioral therapy, interpersonal therapy, all kinds of books. And a lot of my patients say, well, I don't have time to sit down and read. Well, download them and listen to them. You can listen to books while you're doing the dishes, while you're commuting, while you're raking the leaves. And you can at least get some of the ideas into your head and be thinking about them while you're doing something else. You can also start with group therapy and support groups, which can be helpful. There are, again, a lot of online options you don't have to do in person. And I think starting with other people and feeling like you're not alone is a great way to go about it. Finally, I just want to emphasize that in general, our goals really should be healthy mom, healthy family, and healthy community. And we should all consider that, good mental health is part of being healthy. And it should be something that we all talk about the same way that we talk about our cholesterol and our blood sugar, et cetera. It's important that we all have good, stable mental health. And so if that is something that is bothering you or a loved one, then get the help you need. And if I can answer questions, I'll be glad to now. Thank you.
Thank you so much, Jennifer. That was a great presentation. And as a mom of 2 young kids, now working from home as a result of the pandemic, I could relate, at least anecdotally, to a lot of what you presented. We would now like to open it up for questions. If you have any questions, please post them on the social wall to the right-hand side of your screen. When posting, please remember there is a 20 to 30-second delay between the presentation and the stream on Conference Tracker, so please be patient as we review your questions and comments. If we do not have time to answer questions today, please send them as well as the name of the session to connection@namimd.org. There is our first question. Amanda is asking if there is a directory for providers that have expertise in maternal mental health, both pre and postnatal.
There's not a specific provider directory that I know of. However, Postpartum Support International keeps a list of providers that has expertise in that, and can refer you to local providers. And there's often local, I'm going to blank on the name of this, but local state organizations related to PSI. So I would start with Postpartum Support International and see what local resources you can find through them.
Great. Waiting to see if there's any other questions that pop in. So no other questions. We're getting ready to hit time anyway, so maybe that's a good thing. Thank you again, and thank you for your patience. I know we had some technical issues at the start. So thank you again for joining us today. When the workshop session closes, you will be prompted to fill out a brief survey. If you would like to receive CEUs for the workshop, please complete the survey in order to qualify. The next workshop session will begin at 3:30. Be sure to check out NAMI Land and other amazing virtual resources in the virtual exhibitor hall. Don't forget to participate in the resource scavenger hunt. If you find all the resources listed and submit your answers by the end of the conference, you'll be entered in a raffle to win a DSW messenger bag. Thank you again, Jennifer, and thank you for all of you joining us. We hope you enjoy the rest of the conference and have a great weekend.
Great. Thank you. Happy Friday.
Happy Friday.